Hi, I'm Deanne, Programme Lead for Hepsilator. Today I'm joined by Professor Ashley Brown, Professor of Practice for Viral Hepatitis at Imperial College London and the Clinical Lead for the West London Operational Delivery Network and NHS England's National Hep C Elimination Programme. Professor Brown, could you tell us a little bit about your background and what led you to specialise in the field of hepatology and specifically hepatitis C?
So how did I get interested in hepatitis C? Well, I often start my lectures by saying that nobody taught me about hepatitis C at medical school. And of course, that's absolutely true. I graduated in 88 and we didn't actually describe the virus until 89. But I was very lucky the second year that I was a junior doctor, I was working in Newcastle with Professor Maggie Bassendine, who'd had an interest in this virus for some time. Bear in mind, of course, at that time, we'd only just developed a test for the antibody. The PCR tests really weren't around. The treatments were very basic, daily interferon injections with all the side effects that many of the listeners will be aware of. But nevertheless, it really fascinated me that for the first time, we'd actually got a chronic viral infection that we were potentially curing, albeit in very small numbers then. I think the other thing that really attracted me to it was the patients. They were fascinating. You know, they'd all lived really interesting lives. They'd all got stories to tell. So that's really what hooked me into hepatitis C and hepatology as a whole. Then over the years, when I was working in Australia, I did some of the early trials on ribavirin. I came back to the Royal Free just around when peg interferon was being developed around the turn of the millennium. But after that, when I moved to Imperial, the drugs started coming through, all of the new DAAs, and I ran many of those clinical trials. And I loved the idea that I was actually able to access these drugs for my patients far earlier than they were ever going to be able to be available on the NHS. And we treated several hundred patients through clinical trials. And seeing that huge potential, that difference that we could make to people with these fantastic new drugs, with the development of the FibroScan machine, the avoidance of biopsying, nothing that I'm aware of in medicine would ever compare with the satisfaction of taking somebody with a stigmatizing disease, with something that had really altered their lives, and say, I can cure you in a few weeks with a few tablets. So it's a really satisfying area to work in. And I've been very, very lucky that I fell into the right place at the right time.
So Ashley, then, what initially sparked your interest in the operational delivery network aspect?
So the operational delivery networks were set up just over 5 years ago. We'd got these fantastic drugs now, but the reality was that they were very expensive. There was a lot of people saying, well, we can't really afford that for this particular population. We also knew that whilst there was some excellent work happening in certain centres, in particular in many of the big sort of teaching hospital centres, we knew that this wasn't equitable. We knew there was lots of people who were not accessing the best possible care. So the ODNs were set up with this idea that it was equity of access. It didn't matter where you lived, it didn't matter how you'd acquired your infection, that we were going to treat everybody. And there was this real drive from NHS England to say, we want to be one of the first countries to eliminate hepatitis C. Of course, the real crux of this was when we actually combined forces with the pharmaceutical companies and said, we don't want you fighting against each other. We want you to work together. You've all got good drugs. We want you to sell them to us at a decent price. But more importantly, we want you to help us to get out there and find these people who are up to now undiagnosed. So this wonderful collaboration between the pharmaceutical companies, the clinicians, the Hep C Trust, which, is an outstanding peer-led service, working together. And we've revolutionized treatment for hepatitis C in this country. The results speak for themselves. The job's not done yet, but to be part of that right at the start and to help develop it, I don't want to name names, but to pull everybody up to a good standard of care was really, again, an incredibly gratifying thing to be part of.
It really is quite remarkable, isn't it? The national programme and all those systems coming together to, do this one goal, to achieve this one thing. It's quite remarkable.
There is nothing else where so many stakeholders combine. It's not just those three parties I've talked about, but working with the prison service, working with community public health, going out into the community, meeting people where they live, and diagnosing and treating there and then on the spot, not waiting 18 weeks for an outpatient appointment at a certain time, actually adjusting our services so that they are acceptable to the people that we're treating. It's so satisfying.
Mm. So for those who might be unfamiliar, could you give us a brief overview of, hepatitis C, what it is, how it's transmitted, potential health implications if it's not treated?
So hepatitis C is a bloodborne virus. That means that the major mode of transmission is when one person who's living with the virus, their blood mixes with somebody who is so far not living with the virus. And so in this country, in fact, the majority of cases that we know historically were probably amongst people who use drugs, where equipment was shared and blood was passed from one person to another. Even tiny microscopic amounts of blood were sufficient for the virus to be passed. And because of this, that's why this particular infection has been so stigmatized, because this is a marginalized group of people. It's really important, though, to remember that this is not the only mode of transmission. A lot of the people that I'm now treating were born in countries where the virus was more prevalent and where medical procedures were suboptimal. In other words, equipment used by doctors, nurses, dentists could also transmit the virus from one person to another. Of course, we've recently had the contaminated blood inquiry, where we know that some people received blood products that were imported, mainly from the United States, that also transmitted the virus. And it's fair to say there are some people who we never know how they acquired it. The bottom line is it doesn't really matter, because if you've got the virus, we can get rid of it. So let's not worry about how you acquired it. Left untreated, the real problem, sorry, with hepatitis C is that it doesn't really have much in the way of symptoms. So people often don't know that they're living with the virus. The symptoms we do know about, things like poor cognition or lack of energy, are often dismissed by GPs. Or you're just overworking, you're just tired, go and get some rest. So people don't often come forward for testing. But we know that left undiagnosed, untreated, that it can lead to serious liver complications. It can lead to cirrhosis, liver cancer, decompensation. I remember when I was a junior doctor working on the liver wards, that half our beds were filled with patients with hepatitis C, with ascites, with cancer, with liver failure, whatever. My junior doctors now never see hepatitis C because they don't get as far as the hospital. We treat them before they actually need hospital inpatient care. And that, again, is why this is such a good investment by the health service. Although these drugs may seem expensive, the money we're saving, the bed days that we're saving, the misery of patients with end-stage liver disease that we're saving is money incredibly well spent.
Mm. And obviously the operational delivery networks have quite a role to play in that, quite a big role. Could you tell us just a little bit more about the operational delivery network and your responsibilities within that?
So the operational delivery networks were set up 22 geographical regional areas of England, with one person ultimately in charge. But their responsibility, my responsibility in West London, was to work with all of those stakeholders. So not only the secondary care trust, but primary care, the drug treatment service providers, the prison services, immigration services, everybody who touches on people living with hepatitis C, to make sure that we were providing care in a coordinated way, so that we were working together for the benefit of people living with hepatitis C, to ensure that everybody, as I say, irrespective of how they acquired the disease, irrespective of where they're living, that we could actually make sure that each and every one of those individuals was brought into care in a way that was acceptable to them. And so that actually was a complete rethink of the way that we practice medicine in the modern world, where every trust is looking after its own business and fighting against each other for work. On a personal level, it's again been extremely gratifying. I know the colleagues now working in all those different areas much better than I ever did before. I can get a referral from somebody far away from here. I know exactly who to speak to, who is the best person that can engage with that particular patient, who can actually bring them into diagnosis, treatment, and care. And that's really what it's about. It's about equity of access for all.
Okay, so in those terms then, with the operational delivery network working as it is, What are some of the strategies and approaches that the network uses to reach its aims ultimately?
So in order to reach these aims of equity of access, it's first of all important that we work together. Um, I'm a firm believer in the importance of data. So, for example, I receive every week a report of every single person that's tested positive this week in my operational delivery network area. And that means, again, that I can then speak to the people who are delivering care closer to those patients and say, these are the people that we need to bring into care. It means that resources are shared equally. So if a nurse, a single working nurse in one particular service, for whatever reason, is unable to manage her workload or goes off sick, it means we can help each other. It means we share equipment, FibroScan machines, Kefid machines. It means that we meet on a weekly basis to talk about our priorities, our concerns, our current barriers, and we work together to actually overcome those. So, as I say, unlike any other service in this region, we're offering the identical service across a population of over 2 million people living in West London. And that's really revolutionary.
Mm. Could you give us a bit of a flavour of some of the initiatives or programs that you've implemented in the ODN?
So it was really important when we opened up the operational delivery network that we considered where people living with hepatitis C were likely to be found and where we put the resources. As I said previously, the most frequent cause of living with hepatitis C is people who use drugs. And so early on, we put really strong initiatives into each and every drug treatment service in our region. And that meant working with people in drug treatment services, our nurses going out, both in terms of upskilling, in terms of doing testing in those areas, in terms of delivering treatment in the drug treatment services. So that was obviously our initial priority. And we've done pretty well with that. And many of our drug treatment services have now officially declared micro-elimination. As we realized there were other areas where we were going to find patients, we had to develop services. One of the early things that we did was move into the prison. Again, we had we knew that the prevalence in the prison was going to be high, but the old system where patients waited to be brought out to hospitals was clearly not working. It took a lot of barriers to break down, but eventually myself and the pharmacist, we obtained access, our own keys and access to the prison. We go in and we treat patients immediately. We have very good liaison with the nurses in the prison, and they can do the testing and we will ship the drugs in. Same at the Immigration Removal Centre. Other initiatives that we've started, well, on the across NHS England, obviously there was the self-testing portal. We thought that was a great way for people who perhaps felt so stigmatized they didn't even want to ask their GP for a test. So this is an anonymous way that you can order a test online. And so we thought, how do we promote that? So we did a couple of programs where we put the QR code on bus shelters. More recently, we did a big project in Westfield Shopping Centre. People doing their Christmas shopping would have these posters that they could discreetly, catch the QR code on their mobile phone and have a test delivered to their homes. I've always had a strong interest in maternity care and pediatric care. I've done clinics in those services for several decades. So again, we pioneered antenatal screening, and we picked up quite a lot of women living with hepatitis C, again, mainly because they were infected in their country of birth. And that means not only can we treat the mother, but when the child is born, we can test the child. And we've treated large numbers of children now. The new drugs we can treat as young as 4, long before all of the sort of concerns and stigma sets in with adolescents. We used to have to wait till young people were in adolescence with all of those additional psychological issues. But now 4-year-olds, they have their magic sprinkles on their yogurt. They're cured in 8 or 12 weeks, and they never even really know what hepatitis C was. So all these initiatives looking at new ways. The final group I think we've really got to tackle again is first generation migrants here in West London, particularly Eastern European patients. So again, it's getting into those communities again in a way that's acceptable to them. One of the great advances we've recently made is we've been able to appoint an Eastern European peer through the Hep C Trust who speaks a number of Eastern European languages, who can actually, with lived experience, who can engage with these patients, these clients, and bring them forward for testing and treatment. For many, it's a surprise that treatment is free at the point of care, that cures are possible.
So you've mentioned some really pioneering initiatives, some really big wins, and you started to touch there on some of the sort of challenges that you're facing now. So what have been some of the biggest challenges the ODN in particular has faced in tackling Hep C?
The audience faced a number of challenges, and they all basically filter back to ignorance or lack of awareness of the importance of hepatitis C and also the ready availability of treatment. So in many cases where initial barriers have gone up, it's simply a matter of communication, of sitting down, of explaining to whether that be prison officers, whether that be people working in the community, whether it be secondary care staff in secondary care, doctors and nurses working in secondary care or primary care. It's a case really of sitting down and explaining that, this is an underdiagnosed condition. It has fantastic treatment. And the most important thing is we're not asking you to do anything extra. Again, I failed to mention, of course, the incredible work that we're doing with A&E testing. Now, when we first talked about universal opt-out screening in the emergency department, and I did a pilot of this with a PhD student, gosh, about 8 or 9 years ago. And again, all of the concerns, there's consent issues, the A&E staff are too busy, who's going to follow them up, and all these barriers that went up. But in fact, we explained, it's not an issue. We will follow up all of these patients. All you've got, there's no additional, nothing extra for you to do, and we will pick it all up. And, we all know what a huge success A&E screening has been, to the point where, the A&E staff are now saying, isn't this wonderful? And it's like, well, a few months ago, you were the ones that were saying it couldn't be done. So much still exists around stigma. This whole thing that we have to individually consent somebody for a Hep C test. It shouldn't be any different to measuring somebody's blood pressure, doing a chest X-ray, testing their full blood count. It's only stigma that seems to make people think this is somehow different. This is an entirely treatable condition that, left untreated, is going to have significant consequences, both for the individual and for the health service. It doesn't make sense to put it in some special little box that says we have to treat this with kid gloves.
Absolutely. And you mentioned there about the A&E testing, which is one of the, I think it's just had huge impact, hasn't it, nationally, with all of the emergency departments involved. And you mentioned about stigma, which is really important. So, and also about key groups that you're trying to reach. So do you think that the stigma is getting in the way potentially of you reaching key communities that might be at risk of Hep C?
Stigma still remains a significant problem for many people. To a certain extent, it's because hepatitis C tends to be lumped in with other bloodborne viruses. Assumptions are made about how somebody has acquired their virus. And again, what we really need to do as a community is to say, again, it doesn't matter how it was acquired, it's all the same. I do sometimes run up against people who sort of almost talk about guilty ways of acquiring it and the innocent ways of acquiring it. We want to get rid of that. Hep C is a virus, it's a simple infection, it's like catching flu or whatever else. It just needs treatment and we need to get away from it. Let's stop judging people. If we can stop judging individuals, that's how we beat stigma. There should be no shame to being tested positive for hepatitis C. And of course, this differs across different communities. We find that migrants, particularly from certain countries, will be far more stigmatized by this than others. Others are much more open about it. I think one of the things we need to do more about is education for young people. One of the programs that we're trying to get off the ground that isn't quite there yet is about going into schools and talking to teenagers, to sixth formers, about liver health in general, obviously about lifestyle choices in terms of healthy liver, but bringing into that the whole conversation around viral hepatitis, because the only way we're going to beat stigma is by beating ignorance. So let's hope that in the future we can overcome that particular barrier.
That's excellent. Thank you very much. So what would you consider then to be the most significant highlights or successes of the national programme, but also the ODN?
In terms of the national programme, it really is leadership and buy-in. There are a few characters at the top that require praise for actually taking this ball and running with it. It was, if you'd have told me 6 or 7 years ago that we would be in the situation we are now, I wouldn't have believed it. So really, it did come from the top. I think bringing in all stakeholders, in particular, and again, a lot of people say, well, pharma shouldn't be involved. No, we couldn't have done this without the assistance of the pharmaceutical companies, both in terms of a fair price for the treatment, but also shifting away from the purely commercial side of it and actually saying, let's get the pharmaceutical companies involved in patient care, in patient-finding initiatives, be that putting in the CEFID machines, be that paying for peers with lived experience, be that things like the electronic databases that we use in drug treatment services, or the patient identification tool running in primary care. They've made a huge difference. In terms of the individual ODN, it's just this collaboration that, again, I've never experienced working in the health service, that actually makes it a joy to come to work, a joy to work with people. We're all got the same, we're pulling in the same direction. And again, you don't often find that in the health service. But when people get the idea of hepatitis C diagnosis and treatment, and they get into it, it is such a rewarding area to work in. So it's a real pleasure to work with people who are aiming for Hep C elimination, because we're all got the same goal. We all come from different disciplines, from different backgrounds, but we all want the same endpoint, and that's what makes it so satisfying, so enjoyable.
I think a lot of people can agree with you on that one, particularly. So with that, can you think of any particular stories that really illustrate that positive impact that the network, the national programme is having on people's lives?
I mean, I could tell 100 stories of individuals, some of whom I've known for years, because let's be fair, some people rejected the idea of interferon treatment or went through interferon treatment and it didn't work and were waiting for the DAAs. And so I followed them for many years. Some of them sadly have cirrhosis and are still in my clinics, even though they've had successful treatment. What I can say, almost without exception, I think, is that I don't know a single patient that regrets having their treatment, and that the vast majority of people feel better having had their treatment. I don't think we can underestimate, whilst primarily, okay, we're treating to prevent liver disease, and I'm a liver doctor, I'm a hepatologist, but I don't think we should underestimate those additional psychological benefits of ridding yourself of a chronic infection. So many of my patients say, I feel more energy now, I can think more clearly. And I agree that we're only dealing with one aspect of what can be sometimes very complicated patients. But often it's the stepping stone. It's the one thing, that sense of achievement of doing one thing, having a little bit more energy, a little bit more clear thinking, that actually then allows them to move on to address some of those other issues. And we know that a lot of these people have multiple health issues. They may have addiction issues. They may have mental health problems, housing, finance, employment, you name it. And we know that this is not the universal panacea, But for so many people, it is the turning point. It's the fulcrum that actually leads on to starting to address some of those other issues. And I've certainly seen patients, that have gone from literally rough sleeping, homelessness, addiction issues, mental health issues, that have gone through Hep C treatment with, I have to say, the huge support and input from the peers, from the whole team, from multiple agencies having input, but seeing them get back on their feet, getting into secured housing, getting finances under control, getting addiction under control, and actually re-engaging with mainstream society. And again, the knock-on benefits to the country can't be calculated, but are actually huge. I've seen women who get their children back from care. I've seen people get back into education. One of the things I'd love to do a little bit more work on is reoffending in prisons. I know that a lot of the guys that we treat in the prison, do say they feel better. And, we come across them in outside the prison several years later, and they haven't gone back into prison. And maybe just that little effort of engaging, of saying, yeah, we do care about you, and that treatment is available. It breaks my heart every time I offer somebody treatment. They say, oh, well, I'm not worth it, give it to somebody else. It's making me teary now. But and this whole idea that it does mean that we care about them, and that perhaps is also sets them on the path to recovery in the wider sense of the word.
Absolutely. I mean, I often talk about the magic that happens, and it's really hard to grasp and it's really hard to demonstrate in terms of evidence, but there certainly is something happening, because we hear anecdotally again and again that people, they flourish after having Hep C treatment. So it'd be really interesting to, keep an eye on any research that you do in the future that might be related to that.
Yeah.
So looking ahead then, obviously you've got so much behind you, so much that has been done, both in the operational delivery network, but also in the national programme. So what's the next mission or goal for both of those?
So the big question obviously is what happens when we get to the end of the programme or when we declare elimination. And the big worry, of course, is that once you've achieved that target, everything's dismantled. And as we all know, with infectious diseases, that the worry is then that everything is going to start to bubble up again as soon as we turn our back. I'm quite optimistic for the future, to be absolutely honest, because I think, yes, it's true that certain parts of the program will be dismantled, but I think we've actually got two really important things. The first thing is that we've raised awareness of hepatitis C quite dramatically across the board. The work, again, that we've done in terms of raising awareness in primary care is really important, but in the general population, in the general public, I think generally people know a little bit more about it. I think the way that we have shown that we can change how we work in the NHS in terms of moving things out into the community, of multidisciplinary working. I'm delighted that almost every member of my team can do every bit of the thing. We can all take blood, we can all prescribe, we can all counsel, we can all support, irrespective of whether we're nurses, pharmacists, doctors, healthcare assistants, whatever. So that new way of working, I think, will be a legacy. I think the other thing is that we will actually start to expand all of those skill sets into a much wider liver health program. We know that viral hepatitis is one small fraction of what causes chronic liver disease. Alcohol misuse, metabolic associated liver disease, so diabetes, obesity, etc., are major contributors. But the skills that we've learned and the individuals that we've trained up, including the peers as well as the healthcare professionals, actually means that we can approach people in the community with these other conditions. We can manage them in the community. As the new drugs come through for hepatitis B, for fatty liver disease, we can deliver those in the community. So what we've actually done is we've carried out a revolution, not just in hepatitis C, but in liver disease as a whole. At the end of the day, liver disease is mainly lifestyle related, and it's mainly best addressed in the community by people who can relate with lived experience, who can engage with individuals with liver disease and bring them into care and treatment. So it's not the end of the road when we announce Hep C elimination, which I hope we will do before I retire. But it means that we've got this legacy of a new way of delivering healthcare with respect to liver disease as a whole, not just viral hepatitis.
So, for anybody listening that wants to contribute to that legacy of eliminating hepatitis C, a virus in England, how can they contribute or support in the network's efforts?
We would love anybody who's interested to come forward. We're always looking for volunteers. We're always looking for people with an interest. There are 101 ways in which people can help. Both spreading the message, both about hepatitis C and liver disease as a whole. It may be simple things like, actually, if you've got a friend or a relative who you think needs help, we can tell you how best to approach them. It may be that you want to support the Hep C Trust, and as a volunteer, it may be you want to raise funds for the various charities that will support people living with liver disease. But it's easy enough to find out geographically where you live, find out where your local operational delivery network is based, go and talk to your operational delivery network lead. We're not scary, really. We're probably most unlike what you might think most people working in teaching hospitals are. We would welcome requests, advice, input from anybody who's got an interest, because everybody has a part to play. Liver disease is going to be a major health burden on the NHS. We all know the NHS is creaking at the seams, but this is a real way that we can take some pressure off one part of the NHS. So please, 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 if you've got any questions, if you want to offer help in any way, then please contact your local ODN. And if you can't find out who that is, contact me and I'll tell you who the person to speak to is.
Fabulous. Thank you very much, Ashley. And thank you for all of your work across the ODN, but also the national programme. I know you're hugely passionate about it. To anybody listening, if you want to get a test, the simple way to do that is to visit hepctest.nhs.uk, where you can get a test delivered to your home address. It's really simple. And you can also contact us for more information on connect.hepciolator@mpft.nhs.uk.